Bengal, belonging to poor socioeconomic status, and her informants are parents and grandmother. She presented with chief complaints of noisy respiration since 3 months of age, recurrent episodes of fever and cough since 3 months of age, and increased pulsation over the chest since 12 months of age, which was felt by her parents. A baby was born at term via vaginal delivery at local hospital. The baby cried at birth and was apparently normal. Her parents noticed episodic harsh noisy respirations since 3 months of her age. These noisy respirations increased on keeping the baby in supine position and reduced on keeping the baby in prone position. Since 3 months of her age, she started developing recurrent episodes of fever with cough, with rapid breathing, for which she had to be admitted in hospital frequently, around 7 to 8 times a year. Each time she was admitted, she was treated with injectable and inhalational drugs and then was discharged. Her parents noticed increased pulsation over chest since the age of 1 year. Later on, it used to increase after walking and running for some distance. They said it was rapid pounding sensation over the left side of the chest, which gradually reduced on taking rest. Pounding sensation was always regular. They also noticed that she could not match up while playing with her peers and used to stop playing early. According to her parents, there is history of poor weight gain, and at the age of 1 year, she was taken to a local physician for her illness, who had informed about some hole in her heart. For the last 6 months, she is on some medications which have relieved her symptoms to some extent. Negative history. There is no history of any bluish discoloration of skin, squatting, or any history suggestive of cyanotic spell. There is no history of any swelling of foot or abdomen. There is no history of loss of consciousness or convulsion. There is no history of any suggestive of prolonged fever or skin lesion with it. There is no history of difficulty in swallowing food. There is no history of reduced urine output, no history of chest pain, hemoptysis, or any copious amount of sputum production. Birth history. She was born out of a non-consanguineous marriage. She was delivered at term by vaginal delivery at local hospital. She cried at birth. Her birth weight was 2.5 kg. She was discharged 2 days after delivery. In maternal history, there is no history of diabetes.
It was a delivery in a hospital, or where was the delivery conducted?
Delivery was conducted in a primary health center, sir.
So was the parents told that there was some cardiac murmur or something?
Not at the time of delivery. No history of diabetes mellitus or hypertension during gestation. There is no history of any fever or rash during gestation. There is no history of any addiction or drug intake during gestation. In the developmental history, parents noticed normal motor and language milestones. In personal history, bladder, bowel, sleep, and appetite are normal. In family history, she is the eldest of 2 siblings. Her younger brother is 1 year of age and is apparently normal till date. There is no history of similar illness in her family. Her vaccination history is not up to date according to her father. This is a summary. So, in summary,
we wanted a little bit more details about the mother's pregnancy and milestones. See, once you have a congenital heart disease patient, must talk a little bit greater about whether the mother had a fever episode during pregnancy.
No, sir, there is
history of alcohol intake, history of rash in the mother. These things you should give in detail. And in a 3-year-old child who has such a thing, you should tell us more about the milestones. What was the neck holding? When did the child start sitting? And when did the child start walking? These are all very important. Also, one thing I wanted you to have told us is categorically cyanosis, was it found out at any stage? Even if it is negative, it should be clarified in the beginning only that whether parents noted or somebody told them about cyanosis or not.
No, sir. When she was in the hospital, at birth also.
No, later on.
No, later on also they didn't notice. Even when she was admitted in hospital, the doctors didn't inform about any bluish discoloration of skin.
So there was no history of any cyanotic spell during the course of the illness?
No, sir. No cyanosis, no cyanotic spell.
And the pregnancy was uneventful?
Pregnancy was uneventful. Yes, sir.
Okay. Carry on.
Dr. Ballabh, like sir said about antenatal history of fevers and all, and
Yes,
nowadays
sir.
it's always important whether she was scanned, because a lot of mothers would be told during antenatal scanning whether some issue. This always comes to attention. Always try to cover in that whether the mother underwent scannings, was told this, so they are more prepared for that. Okay?
Okay, sir.
The other thing, cyanosis, mother may not have noticed. There's no history, but that
Yes.
is always there. Okay.
Yes, sir. So that cannot be ruled out. But I did not get proper history about the scanning because she could not mention.
Okay.
But I think what Dr. Nitin is saying is very important because these days most women will have an antenatal birth defect scan. So that's important. Mother's age also is important. You should tell us about the mother's age because
It was 18 years at the time of.
So whatever correlates with increased occurrence of congenital disease, as a DM student, you should give that impression on your own to the person who is listening to you that you have looked at all these aspects in pregnancy. Anybody in the family had, this was the first child, but what is the health of the second child? So all those correlates of congenital heart disease, that kind of an impression should be provided to the listener.
Yes, sir.
And Pallav, you mentioned diabetes. It's a question always asked. I'd like to ask you why do you ask history? Is there any correlation with diabetes?
Yes, sir. Because gestational diabetes in mother is associated with some congenital heart disease in children, like there may be transposition of great arteries or corrected transposition of great arteries.
What else?
PSD may be there. Conotruncal abnormalities.
Conotruncal, more than you get HCM, HOCM can be there. And there's a, like sir said about maternal age, there's an instance of truncus arteries and arch anomalies with advanced age and gestational diabetes. That you have to keep in mind. Okay?
Okay, sir. So, in summary, this is a 3-year-old girl child who presented with recurrent respiratory tract infections along with stridor. There is volume overload type of palpitations and poor weight gain.
So here also, Dr. Biswas, your history is very good, but you need to give an impression to the person. See, obviously this is a left to right shunt one can make out from the kind of history you're providing. So one would be interested in knowing whether there was feature of heart failure or not. So whether these were recurrent chest infections or there was an element of child asking for feeds repeatedly, not able to suck for long, excessive crying. So you have to give this feeling to the person listening that, because see, it is a left to right shunt, 7 to 8 admissions you said in a year. So obviously it's a significant shunt which has presented in the first year. So the chance of these people being in heart failure is also these
high.
Neonates is high. So give us a feeling as to in your history that what was the feeding, what was the weight gain of the child, what do the parents feel, did the child not gain weight or gain weight, and excessive sweating during feeding, frequency of feeding, was the child asking for feed every hourly, what was the age of weaning. Now, in a 3-year-old child, you have to start thinking like a pediatrician actually, rather than as an adult MD medicine person. So you have to switch your gears and then start thinking that kind of a frame you have to develop. That how was the child in the first year of life? So tell us about heart failure, tell us about weaning, tell us about weight gain, all these things.
Sir, I asked about feeding history. The feeding history, the parents said that she had poor feeding, but there was no episode of recurrent crying or recurrent waking up of sleep for small frequent feed. It was not like that. She had poor feeding, but
What do you
this
mean by poor feeding, Dr. Biswas? What do you mean poor feeding is what?
Means she would to take small feed and then she would to stop.
See,
But there
because
was
poor
no
feeding is a very vague term. Poor feeding that could be either because of respiratory issues, because of inability to suck. Lot of things could be. Your history has to clarify all that. Otherwise, you will keep getting these questions. You see, you've got a limited time for history. So the
Yes,
more
yes.
vague your history is, more discuss. What do you mean by poor feeding? Please elaborate.
So there was no history of any diaphoresis, or there was no history of recurrent waking up from sleep for small feeding. But she did take small feed and then she used to go off to sleep. But there was no recurrent waking up at night. There is no recurrent crying. So I could not incorporate that history into my.
So what you should say is whether the child had continuous or interrupted feeds interrupted by some episode of breathlessness. Normally, a normal child will feed continuously for about 5 minutes or so. But
Yes,
the
sir.
children who have heart will have 30 seconds when they'll stop, they'll have diaphoresis, they'll have breathlessness and feed. And normally a child who's well fed will sleep for about 2 hours between each feed. The child who does not feed enough feeds only 5 minutes and wakes up in half an hour. Those things should be clarified.
But there was, yes, sir, but there was poor, there is history of poor weight gain. That was very categorically.
All right.
Do you understand Hindi, Dr. Pallab?
Yes, sir, I do.
So something like you should ask कि सर पे माथे पे पसीना आ जाता था जब फीड लेता था बच्चा, वेदर 1 घंटे के बाद फीड मांगता था या 3 घंटे के बाद मांगता था, 2 घंटे के बाद. So that kind of things, direct questions, once they have given their own point of view, as Dr. Nitin is saying, give us a dissection kind of a thing as to poor feeding is one thing, but why poor feeding? Is it child is getting fatigued? What is happening to the child?
So diaphoresis I asked about in local language. They could not mention it properly. But this one, recurrent feeding at night was there, but diaphoresis was not there.
So what is your impression from the clinical history about the, can you make any diagnosis from the history alone?
Certainly, sir, there is a left to right shunt. Most likely because of recurrent respiratory tract infection, there is a significant shunt. But one important point is that there is stridor from stridor. There is history of stridor, which is.
How do you explain the history of stridor?
Yes, sir. Stridor can be either due to any compression over the respiratory tract, or it can be due to some abnormality in the trachea itself, like tracheomalacia, or there may be this compression may be due to vascular ring, or it may be due to any abnormal vessel or abnormal structure compressing over the respiratory tract.
Okay, and your history of stridor is, you said more stridor on supine and relieved on prone.
Yes, sir.
Yeah. So, and is there a history of the stridor worsening during feeds? Is it when you want to say something like vascular incomplete, always correlate with history of choking? That gives plus points to you, because more you elaborate history, the lesser questions come back to you. The exam knows that you're proceeding in a certain direction.
Yes, sir, but there is no history of any choking or dysphagia. The patient and the parents, they said.
Tell us what is orthopnea, what is platypnea, what is trypopnea. Tell us what are these terms. What do they connotate?
Sir, orthopnea stands for respiratory distress in supine position, which is relieved on sitting up or standing. Platypnea is respiratory distress.
I don't think we take standing in this.
Sitting up, sir. Yeah. In platypnea, there is respiratory distress in upright position, which is relieved on lying down. Trypopnea, sir, there is respiratory distress on sideways, on lying in a particular side, which is relieved on taking the other side, turning over to other side.
Good. So analyze this history for us, as Dr. Banerjee was asking you.
Yes, sir.
What are your thoughts on the may not be diagnosis, but what are your thought process on the history that we have got? Anything else in the history you would tell us, or that's enough? That's
So,
No, sir,
Pallab,
nothing.
what you have said about the history with left to right shunt, and is it a left to right shunt without background of cyanotic disease or acyanotic disease? What is your impression?
Most likely, sir, it is without background of cyanotic disease. Because
So, why do you say that? Is there any cyanotic disease or there may be typical presentation of large VSD? Patient may present with just like large VSD without any history of cyanotic spell or obvious clinical cyanosis. Of course, you have not done any clinical examination as yet, but
Yes, sir.
did you get any history of cyanotic spell anytime during
No,
the
sir.
course of the illness?
No, sir. There
So
was
you
no
are-
history of any spotting. There is no history of any cyanotic spell.
so as you rightly said, it's a high flow. It's a high flow. Can you just tell us supratricuspid or infratricuspid? At least that much you should be at by the age of presentation of the patient.
Because yes, sir. Because
That feel you-
because she has presented very early in age, along with recurrent respiratory tract infection, and along with a history of some doctor diagnosing her already with a hole in the heart. Most likely, it is a post-tricuspid shunt.
tell us,
Infratricuspid.
Post
You are talking about infratricuspid.
Yes, sir.
Is there a history of hospitalization for the LRDA?
Yes, sir. Every time there was LRTI, mostly she was taken to a hospital where she used to get
7, 8
injected.
admissions
7,
is-
8 times in a year.
Yes, sir.
Now, Dr. Biswas, you are going towards increased left to right shunt.
Yes, sir.
Like Banerjee sir asked you with the sinusitis. Suppose there was a history of sinuses. Okay. Now,
Yes, sir.
Increased pulmonary blood flow, cyanotic versus acyanotic. Does it raise some red flags? What is more important for you?
If there is cyanosis, increased blood flow with cyanosis.
Yeah, exactly.
So what is an admixture lesion? Dr. Nitin is asking you, what are your thoughts regarding an admixture lesion which will have cyanosis as well as increased pulmonary blood flow as against a pure left to right shunt? Is it right, Dr. Nitin?
Yes,
That's what-
exactly.
Yeah.
So there may be the cyanosis with increased pulmonary blood flow may be seen in conditions like truncus arteriosus, or there may be in AVSD, or there may be in single ventricles. And
What is acyanotic fallow?
a cyanotic fallow is where there is restriction towards in the blood flow towards pulmonary artery, but there is no significant cyanosis, mainly because of increased blood flow to the pulmonary artery via MAPRAs or other shunt. Or the pulmonary stenosis might be not so significant.
So what is the actually pathology behind which the intensity of cyanotic depends on pathology of fallow?
So, sir, it depends on the degree of pulmonary stenosis.
What about the overriding of the aorta? Does overriding of the aorta matters in the intensity of cyanosis?
Yes, sir, it does. If there is a significant overriding of aorta, it may be a lesion of DORB.
So that is implicit in the definition of TOP. So you are right, actually, that it's the RBOT obstruction which determines the extent of right to left shunting.
Yes,
And though, I mean, there will be VSD, large, unrestricted, aortic override will be there. But it's the RBOT obstruction extent which will determine the amount of cyanosis.
Atomic sinus. Yes.
I think we'll have to move along.
Yeah, yes.
Okay, sir. In general survey, the patient is conscious, alert, and cooperative. Facies is normal. Decubitus is of choice. Height is 83 centimeter. Weight is 10 kg. Both the things are less than 2 standard deviation from the mean. Medium circumference is 11.5 centimeter. There is pallor cyanosis, clubbing icterus, and edema are absent. JVP is not raised. Waveforms are normal. Pulse is 112 per minute, regular, normal in volume and character. No radioradial or radiofemoral delay. Equally palpable in all 4 limbs. BP is 100 by 70 millimeter of mercury in both upper limbs and 102 by 76 millimeter of mercury in left lower limb. Saturation is 97% in both upper limb and 96% in both lower limb. Respiratory rate is 28 per minute, abdominal thoracic in nature.
So here, up till here, you should give us actually, if you go back 2 slides back, this one, you should tell us what percentile is the child's growth, because at least I have no sense of in a 3-year person height, ye kya hai, 83 or weight. So give us an impression, what is the percentile?
The height and weight both are less than 2 standard deviation from mean, that is less than 2 percentile of the.
Right. So that's very important, that what is the growth of this child and what is the physical development. Okay, good. Something about the mental, conscious, alert. Yeah, that's fine. You just said progress, so that's okay.
Yes.
So you need to give an impression of other congenital anomalies you looked at, whether there were any, because a lot of these children will have associated upper limb and cleft lips, and so.
No, I looked for cleft lip and cleft palate, sir. There was no cleft lip and palate, and the upper limb, the bony structure was also normal.
Good.
There was no evidence of any
no abnormal faces.
Yes.
But this was your
Yes,
face.
sir.
When you say face is normal, very good. What if you just say there's no dysmorphism or stigmatus is coming out, then it sort of covers everything. All right.
Okay, sir.
Okay. Just brief. What are the eye abnormalities you look for in CHD? Only eye. Restrict yourself to the eye.
Eye abnormalities, there may be hypertelorism.
In what?
Oh, in sir, there may be Dijor syndrome with hypertelorism.
Okay.
For conotruncal abnormalities. Sir, there may be.
Do you get in Downs?
Downs, sir, we can get strabismus.
Okay, next, after hypertelorism, what else?
We can get, sir, coloboma in Chart syndrome.
Okay.
We can get epicanthic fold in Down syndrome.
Simian crease, all those things.
Simian crease we can get in Down syndrome.
Yeah. So give an impression, but you don't need to mention it at your level. But just if somebody asks, you should be.
So all these are I looked for, or there may be low set ears, low hairline. All these I looked for, sir, but I didn't get anything. This was not.
Because Down is important. You see, in a child,
Yes.
left and right shut. It's more important. Okay, good.
No.
So basically, general exam is nil, except for growth retardation, everything is normal.
Hey, you
Yes.
mentioned in the history a lot about the Strider, but on your examination, you have made no mention.
Sir, it is episodic, sir. It is not present all the time. When I examined her, it was not this. And there was no the chest abnormalities. I expected some chest abnormalities like Harrison sulcus and all for recurrent respiratory tract infection. But I did not get some.
No, you have to mention in a case like this because stridor is one of the first symptoms. So you
Yes,
say no Harrison sulcus, axis and muscles of respiratory not prominent.
Not
That
prominent.
gives an idea that you have looked for all. So you don't
Absolutely.
get counter questions. You have to finish that, especially when your main symptom is stridor, one of the symptoms, right?
Yes,
You
sir.
have to be more elaborate to illustrate all that.
Yes. In CVS examination in inspection, chest is normal in shape and symmetry. There is visible pulsation over the left side of the chest. There is no scar in left upper side of the chest, no scar, sinus or ulcer. In palpation, the apex is present in the left fourth intercostal space, 2 cm away from the mid-clavicular line, diffuse in nature with lateral retraction. Grade 2 parasternal impulse is palpable at left lower parasternal area. There is prominent pulsation in the left second intercostal space. There is presence of systolic thrill at left second intercostal space. In percussion, liver dullness is on the right side, gastric tympanicity is on the left side. Left second intercostal space is dull. In auscultation, S1 is normal, S2 is single, S3 is audible at left lower parasternal area, which increases with inspiration. S4 is not audible. There is a murmur. There is only one murmur. Grade 4/6, systolo-diastolic, to and fro murmur, audible at left second intercostal space. Just heard with the diaphragm of the stethoscope in sitting upright position, in leaning forward position.
Could you go back, Dr. Prasad? One slide.
Yes, sir.
You said presence of systolo-diastolic thrill.
Yes, sir.
You could make out it is totally.
It's very odd to make out a systolo-diastolic thrill. That's what Dr. Nitin is.
Yeah.
You heard a murmur, we agree.
Yes,
But
sir.
I mean, it's not easy to.
Saying systolo-diastolic thrill is a red herring for you. Will get questions on that. Rest of the exam will be left out. Yeah. Whatever you want to postulate, you can also say there's a thrill and left second intercostal space.
Yes.
That's okay. That won't be questions on, because you won't have a direct. It has spaces. You're in not on firm ground when you say this. And then pucker, should we say the right heart border? That is it normal? Did you pucker?
Yes, sir. Right heart border is normal.
So obvious question is, what is the systolo-diastolic murmur? What is the continuous murmur? Why you are calling it as a systolo-diastolic? So tell us why you chose systolo-diastolic. How do you distinguish it from a continuous murmur? Tell us more about it.
Systolo-diastolic murmur is a murmur where there is a systolic part and a gap followed by a diastolic part present in the same area. Whereas in the continuous,
it is heard in which all conditions?
Systolo-diastolic murmur can be heard in in aortic stenosis with aortic regurgitation, in pulmonary stenosis with pulmonary regurgitation. Rarely in ruptured sinus of Valsalva can be present.
And what is the continuous murmur?
Any other condition? You're talking of left to right shunt. Any other condition? Common ones.
Common.
I think systolic, not you're saying systolic diastolic, no?
Sir, maybe if there is ventricular septal defect with AR.
That should come first. That should come first, right?
That is very important. Yes.
And what is the definition? What do you mean continuous murmur?
Continuous murmur is the same murmur which carries over from systole into the diastole, and it overlaps the second heart sound.
Yeah, it marches through the second sound.
It marches.
This has to come. This has to come. Okay.
Yes.
So in a continuous murmur, you should tell us about eddy sounds are there or not. In a systolo-diastolic murmur, you should tell us about the character of the systolic and the diastolic. Once you have said it's a systolo-diastolic, and as Dr. Nitin is telling you that VST, AR or ASAR are the commonest causes. So we'd like to know then, in that case, once you call it a systolo-diastolic, you have very rightly told us the distinction between the two. But in that case, then we would be the second thing which obviously comes to our mind is it a pan-systolic murmur? Is it an ejection systolic murmur? What is the kind of murmur you think? And about the diastolic murmur, also tell us your thoughts.
So it is most likely a ejection systolic murmur, and it is a long duration murmur. But I could not tell about the severity because P2 is absent. So I cannot correlate with the splitting, or I cannot correlate with P2. And the diastolic murmur is also long diastolic murmur, more than half of the diastole it is occupying, and it is associated with the thrill. So most likely it is a severe murmur.
We're not sure whether it's ejection, so it could be pansystolic also, isn't it?
Pardon, sir?
It could be pansy. You're not sure with the ESA. It's not crescent or decrescent, right? You're not too sure.
It is the character is crescendo decrescendo, but I cannot hear the P2, sir. So I could not tell about
contradictory thing, Biswas, actually. Once you say systolic diastole, I have no objections to what you're saying, but it's a little bit odd thing that you then second you say that you can't hear the second heart sound. What did you say?
Yes, sir.
Huh?
Second heart sound is single, sir.
In a second, okay.
Where did you auscultate?
Pardon, sir?
Second heart sound, where did you auscultate?
I auscultated. I found it in the right subcostal, subclavicle, right second intercostal.
Right or left?
Right. Right.
Right subcostal.
S2 is
Right.
best audible where?
Right second intercostal.
Right second intercostal. No, you should never. How will you hear the pulmonary component in the right second?
You're not right, you're wrong.
What is the explanation that you are getting on the right side?
If you can hear the two components, you almost never hear it. And when you're hearing there, obviously you're mixing up right and left, but that will only be in severe pulmonary artery hypertension that you'll be hearing two components of the left hearts. The second sound is always looked at in the left second intercostal space.
Unless you want to see dextrocardic.
Unless.
Probably a mixed up.
So now what is your diagnosis?
Sir, here I have a RBH type of cardiomegaly along with
Sorry?
the
Can you just re-say that? What you said?
RBH type of cardiomegaly.
What
Right.
is
RBH?
He is
RBH?
talking.
What is
He
that?
is talking. RV is enlarged. He is talking.
RBH, yes, sir. RBH in
No, are you saying H or not?
He said
No, no.
H. He said RVH.
I said, sir, but it is RB type of
But you
cardiomegaly.
never say H here. How can you say H?
No, no, sir.
Apex will only tell you whether it's a RB or
Or
a LB. What is the chamber which is predominant, which is volume overload? Hypertrophy cannot be picked up on the apex.
So, sir, it is a right ventricular
See, what
enlargement.
Dr. Banerjee asked you was, you should be very clear in your mind. He has asked you diagnosis. You are giving explanation. Examiner is asking you diagnosis. You are giving explanation. Why should you need to justify? You give he said diagnosis. He could have asked you that also. He has a choice. So once he has asked you diagnosis, you tell us your diagnosis. Then you justify. Then obviously we will all ask you how do you justify it. आप अपना diagnosis बताइए. आपसे पूछा गया diagnosis. आप अपना diagnosis बता दो.
Okay, sir. So, this is a case of situs solitus, congenital acyanotic heart disease. Most likely pulmonary stenosis with severe pulmonary regurgitation, without any feature of congestive heart failure or infective endocarditis present in sinus rhythm.
Dr. Biswas, from what the history is there, failure of urinary infection, all that, I would rather say it is VSD AR.
Absolutely.
That will be first on the list.
I mean,
VSD.
that's the last diagnosis which anybody will make, Dr. Biswas, PSPR in a patient who has repeated chest infections, patient getting admitted. PS patients are, firstly, PSPR is very rare.
Yes.
Alone as an entity, I have never seen it actually. So you're diagnosing it for the first time. It's very, very odd actually. Secondly, patients of PS present very different. PS patients will be low output state.
Yes,
PS patients, yeah. So they are not going to present with how can you ignore the history of repeated chest infections and all that you have is a systolic diastolic pump. I mean, you hardly have any. So how can you ignore the history in such a patient?
Yes, sir. It was difficult, but in VSD, sir, I expect a LV type of apex.
In a small 3-year-old child, apex is not the only thing on which I'm going to put my whole money on. And how sure am I in terms of being able to distinguish an RV and an LV apex in a small child? I mean, you have to take things in totality. You can't just say on the basis of apex only.
Again, where the murmur Raynaud should have is long ejection or pansystolic, and history from 6 months away. So VSD-AR should always come first. When you say PSPR, it shows as if you actually know the diagnosis. Don't give such leading answers. No.
I have never made a diagnosis of PSPR in my whole career actually. PS you will make, but PSPR, loud murmur, I mean, it's a very, 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 very odd diagnosis to make.
Yeah, this is Dr. Dayasagar. I just have one question to the candidate.
Yes,
Is this diastolic murmur, is it early diastolic or mid diastolic?
It's early diastolic.
So in PSPR, what kind of diastolic murmur you get it?
So generally, it is mid diastolic.
Yeah. So how can you say that it is when you say it is early diastolic murmur?
What is the commonest cause of early diastolic murmur?
Aortic regurgitation.
Very good. What is the second commonest cause?
Sir, PR due to pulmonary hypertension.
Excellent. So even in your Harrison, it is written that 9 out of 10 times it will be aortic regurgitation, and 1 out of 10 times it will be pulmonary regurgitation, what you call as Gram-Stein murmur or PR murmur. Okay. So this, your PSPR doesn't even come in that kind of a discussion when you say what is the early diastolic murmur, isn't it?
Yes, sir.
Now, another point is important. Do your blood pressure support the diagnosis of significant AR?
No, sir.
Because what was the diastolic question?
70 millimeter of mercury in upper limbs.
So there is no runoff.
No,
so
sir.
Automatically, this is the only one point. And also there is, as Dr. Wonder was telling, that clinically you may not appreciate whether the left ventricular type or right ventricular type of apex, but at least blood pressure can guide you whether the patient has got a significant AR or not. Okay.
Yes, sir.
Okay. Next. So what are the differential diagnoses?
The differential diagnosis, sir, first was ventricular septal defect with aortic regurgitation. This was other was truncus sarcoidosis with truncal regurgitation, maybe patent ductus sarcoidosis or structured sinus also. These were the other diagnoses that we are discussing.
So you can discuss from below upwards your thoughts on these 4 differential diagnoses that you are keeping. Why you are keeping, tell us, and also tell us why you are keeping lower down.
Yes.
So ruptured sinus of valsalva is your 5th diagnosis, PDA is your 4th, truncus is your 3rd, VSD-AR is your 2nd, PSPR is your 1st. Yes. My first diagnosis is your 2nd one, and your 1st one is my last actually. So tell us your thoughts, what your thoughts are about each of these things. Then we'll see. Do we have time, Dr. Dayasagar? How much time do we have?
It is 20 minutes.
Oh, carry on. Quickly tell us, because probably ECG X-ray will also be available. So we have to spend a couple of minutes on that. So tell us quickly, let's finish off with the clinical aspects.
So because most common diagnosis in this scenario would be ventricular septal defect with aortic regurgitation. But again, the BP and the apex, they actually...
आप RSOV के बारे में बताइए.
RSOV, yes sir. The ruptured sinus of valsalva may be from sinus of valsalva to RV or to RA.
What age do you see patients of RSOV?
Generally, they are seen in older age, sir. And this starts with chest pain followed by the rapid deterioration of heart failure, which is not seen.
Certainly not the kind of RSOV presentation that you must have seen in the 3 years. No? You must not have never seen such a. So the RSOV diagnosis comes only when there is a continuous murmur, sudden chest pain, young male adult comes, isn't it? So yes, common things common. Okay, fine.
Patent ductus arteriosus I kept because of this increased left to right shunt, along with a murmur, with a significant murmur. But again, this has a continuous type of murmur with the diastolic increment. So this is also not matching with my diagnosis.
No, it could still match, Dr. Biswas, because you got symptomatic from the age of 6 months, failure to thrive, recurrent infections, and you got agreed there are no eddy sounds. And if you can distinctly hear systolic diastolic component, then I agree with you. But sometimes when you got a long ESM or PSM and EDM, it may be difficult to differentiate. When you two different components agree, but that still can be missed up. I mean, I don't say EDA is not out. It's still there.
And common things are always common.
Common.
Dr. Nitin is saying. So, although we have strong objection to RS, we have find it odd. PDA, nobody will ever find odd in such a scenario, because as Dr. Nitin is saying, it becomes difficult to distinguish at times, and also common things should be thought of commonly. See, echo might show something, we are not bothered about it. At least our line of thinking has to be in the direction that we are likely to be right more often than, isn't it?
Yes, sir.
Okay. Then the third one?
Third one is truncus arteriosus with truncal regurgitation with stenosis, maybe, sir. It may also present with similar heart failure with the systolic murmurs. So, but then again, heart failure should have been a very prominent.
Right. So these children, as Dr. Nitin initially said, at mixed region, they'll be much worse off. Their prognosis, they develop PAH much earlier. And most of them are lost. So
surviving is 3 years,
yeah. Right.
But the closest it is a ventricular septal defect with aortic regurgitation. Other than normal BP and a normal pulse, it is very difficult to say that.
Dr. Biswas, can you get a normal pulse pressure in AR?
Normal pulse in AR, yes, sir.
A scenario where AR is out of no doubt, but now it's not wide pulse pressure. There's no systolic hypertension.
So if there is any arrhythmia or if there is left ventricular dysfunction, then we can get.
That is one of the caveats. Yeah. Okay. One more thing that will always come in such a 3-year-old child with single second heart sound, LTJ can always fit in everything. When you got severe PH also, the diastolic component is difficult, but LTJ will always be there. When you got such a symptom, when you got a single second sound, you can always be counted. It's rare. That's it.
Yes.
Okay.
This is a chest diagram, PA view, with mild rotation towards the left, and it is a over-penetrated film. Sorry, sir. What we can see is that there is cardiomegaly. The cardiothoracic ratio is obviously more than 0.6. The apex is upturned. There is significant dilatation of the pulmonary artery and main pulmonary trunk, sir. The right descending pulmonary artery also appears to be dilated. There is indentation on the right side of the trachea. Probably there is a right-sided aortic arch. And I cannot comment over the pulmonary vascularity, sir, as it is overpenetrated.
Why you can't?
No, just sorry.
Why you said you can't pulmonary vascularity?
So because it is overpenetrated.
No, but still it appears plethoric. Yeah.
Still, there is visible plethora. No? I mean,
What about right heart border?
In right heart border, sir, right atrium appears to be enlarged.
Yeah. If you got a cardiomegaly, upper and apex, pulmonary plethora, prominent pulmonary conus, and right atrium and lung, where does it lead to?
Probably we are dealing with the right-sided pathology which is associated with the dilatation of the pulmonary artery. So along with the right-sided aortic arch. So most likely, sir, we can think of something other pulmonary stenosis or pulmonary regurgitation, sir.
Can you think of a condition where there is plethora and right aortic arch?
Pardon, sir?
Can you think of a clinical condition wherein there is right aortic arch with pulmonary plethora?
Aortic arch, sir, it can be present in truncus arteriosus.
You are not considering that.
Yes, it may be present. But in pulmonary, the pulmonary trunk is very broadly dilated, which is generally not seen in truncus artery.
what is a Gervais shunt?
Gervais shunt, sir, when there is a connection between left ventricle to right atrium.
Okay, besides you said right aortic arch, what is the implication? Where is it common? I want to give a list. This will always be asked you. Commonest in which condition?
Truncus arteriosus.
Next commonest.
Tetralogy of Fallot.
Pulmonary arteries or TH or severe tau. Third condition.
It may be seen, sir, with the VSD.
What about normal individuals?
Normal individuals?
Can it occur normal? In 3% normal, it may happen.
Okay, sir. This is a lateral view where we can see, sir, RV enlargement. All of the retrosternal area has been occupied by, sir, the RV. There is no space left.
You said the age of the child is 3 years, right?
Yes, sir.
Okay.
So this is a ECG. It is a 12-lead ECG with normal standardization. The rate is around 110 per minute. Rhythm is regular. Each complex is preceded by P with a fixed PR interval. Most likely it is a sinus rhythm. Axis is around, it is equibiphasic in AVF and negative in 1. It is positive in AVR. Most likely, sir, the axis is 170 plus 170 degree to 180 degrees. What we can see is there is prominent P wave with notching in lead 2. There is prominent upright P wave in V1 with only R component in QRS. There are large equibiphasic complexes in V3 and V4. In the V6, there is a Q wave with upright T wave. So most likely this is the case.
What is the chamber hypertrophy here?
Because there are equibiphasic complexes in V3, V4, most likely biventricular enlargements. There is RVH, as we can see from V1, R is greater than S. There is also Q wave in V6, most likely some volume overload is present, and means non-influx Q wave in V6.
Alright. Atrial enlargement? Atrial, no, not seen.
In atrial enlargement, so there is a in lead 2 we can see notched P waves. So most likely P pulmonary. Most likely sir P enlarged, right atrial enlargement.
All right. Yeah. One more thing, Dr. Biswas, when you had this striders in your respiratory, you should mention about air entry. You should give a detail of respiratory system also. Because the history of stridor, which is not common with cardiovascular disease, right?
Yes, sir. I looked for tracheomalacia, sir. There was no trachea or laryngomalacia. It was not present, sir. The air entry bilaterally was normal.
Okay. Okay, now what do you want to see in echo? Now that you have some, what all do you want? Just give me the points 1, 2, 3. What do you want?
Sir, because there is a left to right shunt, I would like to search for the position of the shunts. Whether there is a VSD or a PDA, most likely it is a infratricuspid shunt. So I would like to look for that. And also there is a diastolic murmur. So which may be either aortic regurgitation or pulmonary regurgitation. I would like to confirm that. So mainly these two I would like to.
So now we are all in the same track. The diastolic murmur you want to attribute either to KR or PR to PH, isn't it? Now I think we're all thinking in the same lineage, which is a more simpler and more regular kind of a thinking rather than thinking of PS with PR, isn't it?
Yes, sir.
Pallov, you have said there is a single second heart sound. Okay?
Yes, sir. Yes, sir.
So do you like to, with this auscultatory feature, do you like to see the great vessel relationship?
Yes, sir.
What is your backup in the mind?
Sir, if it is a case of tetralogy of Fallot or L-post aorta, we can get the single S2.
So great vessel relationship is very important in your case, as you have already mentioned. There is single second heart sound which is loud. So
yes,
whether there is any dextroposition or there is any L transposition, all these things have to be looked out. Okay, so this is very important finding in the echocardiography. Okay.
Yes, sir.
Okay, next, carry on.
These are parasternal long axis view, where we can see a large VSD with less than 50% overriding of the aorta. This is the color flow, sir, where we can see the shunt should ideally be equally balanced shunt, but here we can see that mostly the flow is from left ventricle to right ventricle.
Yeah, it's bidirectional, mainly left to right.
Yes, sir.
Is there any aortic override in the PLAX view?
No, sir.
You have not shown
the aortic overriding is less than 50%.
It is not shown in this view. I don't know what apical. Yeah, there is some. That's right. Okay. Okay. I see any conus issue, aortomitral continuity. Would like to comment?
Aortomitral continuity is maintained.
All right, go ahead.
This is the pulmonary artery, sir, where we can see that there is no definite valve tissue in the pulmonary area. There is a thickening. There is a ridge-like structure, but also there is a significant gap in between them. So this may be a case of absent pulmonary valve. This is the color flow where we can see there is frank regurgitation.
Severe PR.
Severe PRs.
What is the gradient across RVOT?
So I got a gradient of 96 millimeter mercury.
You are
And-
overestimated. See, PR is there for sure, no doubt about that.
Yes, sir. And sir, the peak PR gradient was around 40 millimeter mercury.
What else? What else are you seeing? What else? Complete your whole reporting on this. Not this view, the second view, the short X view that you showed. Yeah. No, go back one more slide. Yeah. What else are you seeing?
Presence of sir VSD. Yes, sir. The VSD, whether it is perimembranous or outlet VSD.
No, what do you see in the, just go back one more slide. After the PLAX, you showed the short X, isn't it? Okay, doesn't matter. Go ahead. Just what all you can. Yeah, this exactly. Come in. You don't see the VSD here. You see a small annulus, right? Are you
Yes.
seeing valve leaflets?
Yes, sir.
Can you see leaflets?
Leaflets of the pulmonary valves?
Yeah.
No, it is not seen, sir.
Then what else do you see?
We can see, sir, a ridge-like structure with a significant rent in the middle.
Or what else?
Dilated pulmonary artery.
Yeah, you should talk of that. Pulmonary arteries.
Pulmonary artery is dilated, sir. It is
Yes, sir.
dilated more than the aorta. So there is significant dilatation. So, sir, CT angiography would have been a better mode of investigation. But in
We'll
echo,
come to that later. You're not yet finished echo. Yeah. Okay.
sir, this is the measurement, sir. Main pulmonary artery measures around 2.8 centimeter.
And then in the exam, if it's possible, always talk of Z-scores if you have access to that. If you don't have, that's okay. But when you say dilated pulmonary arteries, aneurysm pulmonary arteries, always put a Z-score if it's possible. If you can't, it's all right. No.
So I did not get Z-score, but what I found out that it is generally compared to the ascending aorta or descending aorta.
Right.
So that is the reason, sir, I could not.
All right.
This is 5 chambers. This is color.
Here it looks like a 50% override, at least in this view. See, any large VSD can get some amount of malaligned override, how you angulate the probe.
Yes.
All right. Comment. Finish your reporting on this. Apical 4-chamber view, you see a large malaligned VSD. Go
Yes,
ahead.
sir. This is an apical 4-chamber view with a large VSD with around 50% overriding of the aorta, where we can see mainly balance shunts. So the balance shunt are mainly left to right.
You talk of the RV size also. You see, it's not a usual RV size. Tell us.
RV is enlarged. RV, but the RA is not enlarged as we had seen in the X-ray. But the RV size is definitely enlarged.
Always comment on additional VSDs also. Every case, we always focus so much on the malaligned VSD. Sometimes forget to always, in practicality, you have to, and always in a case, you always mention additional VSD. That's your plus point. All right. Okay. Any other views you'd like to see? Go ahead.
No, sir, I don't have.
No. What are the views you want to see? Now ventricular function looks okay. RV says that RV function looks all right. LV function also looks all right. All right. What are the views you want to see now? Any more?
One of the, sir, I would like to see the RVOT view to look for the size and the direction of flow in the VSD at the position of the VSD. Anything else?
You know, congenital heart disease echoes always start with subcostal. You always start with PLAX, that's another thing, but subcostal is prime. All right. You always have to do in subcostal. You can't say no. It starts with subcostal. And have you done subcostal?
It is not present in this slide. It is there with me, sir.
All right. Then do you want to see suprasternal view?
Yes, sir. Suprasternal view.
What do you want to look for?
Direction of the aortic arch, and sir, presence of any other associated disease like PDA or any coarctation if present.
Anything else? Anything else in suprasternal view? Given the age of the child, the history and things that we discussed.
Vascular rings are any origin of the arteries, branches of the aortic arch.
Branches of the aortic, presence of, look at the arch anomalies for vascular rings, because we are all think of dilated PS, but vascular rings has to be ruled out.
Yes.
Okay?
Yes. So this is the baby, and so there is no history of any sinuses or cloggings.
Okay, question for you, Dr. Biswas. Suppose you've got a child like this, there's no sinus, mother does not give history of sinus, and you think it's a cyanotic heart, may not be this, maybe an older child, 5 or 6 year old, and on exam you don't find sinuses. What will you do? You're sure it's a cyanotic heart. You can't get caught in exam. What will you do?
We can ask if the baby can walk or run. We'll ask the baby to walk for some duration, and then we can check for the sinuses.
How long?
Around 6 minutes. Sir.
No, the actual thing, of course, this is a smaller child, but until you reach target heart rate, you can make them exercise. Older children, of course, and then look for sinuses.
Then look for sinuses. So we did that.
Child. Yeah,
but
this is too small child.
Yes, sir.
Okay.
So there is a lot of learning in the X-ray. If you go back, Dr. Biswas, to the X-ray, have a relook.
Yeah, go back. Yeah.
There's the whole pulmonary artery, which is.
Yes, so the whole pulmonary artery is dilated. The right pulmonary, descending pulmonary artery is also dilated.
Right.
So, sir, this is a case of absent for tetralogy of Fallot with absent pulmonary valve.
Actually, this X-ray is quite typical of that. So once we know the diagnosis and we go back to this X-ray, and a hugely dilated pulmonary artery with right pulmonary artery also dilated, and not the dilatation is not like that what is seen in pulmonary stenosis patients.
Yes, sir. It is also dilated in pulmonary stenosis, but not to this extent.
It's a localized dilatation, post-stenotic dilatation.
Post-stenotic dilatation.
So,
Dr. Biswas, now that you know, okay, but you cannot say PSP and initially what you could talk of PSP, like Sir said, you never get infection in PS, right?
Yes, sir.
This you got the small annulus is there in good grain because regurgitant flow, right? It's a small annulus absent pulmonary.
Yes.
So clinically to say PS, you can't say on a basic history at all. There's no way. You'll be caught.
So lesson is described entities should be considered. We should not think of entities which are not described, isn't it?
Yes.
Yes, thank you.
But very well presented and very well discussed. This was very impressive.
Thank you.
Do you want to do any other tests?
Actually, sir, we had planned for cardiac MRI to look for the proper anatomy.
Okay.
But for technical reasons, we could not get it done.
Okay.
We had also thought of getting a CT pulmonary angiography done, but again, that was also aborted.
Okay. So, do we have some time?
I'd like to discuss about the therapy.
Yeah.
Therapy, sir. Primarily, this is treated surgically, sir. There is no significant advantage over medical therapy.
No advantage. Yeah, right.
So, mainly, sir, surgical therapy where there is reduction in the size of the pulmonary artery with a there may be a shunt with valve proceed from RV to pulmonary arteries. Details of the surgery, I don't know.
Yeah, call it intracardiac repair with RVPA condo. All right. What would you like to do for pulmonary arteries?
Pulmonary artery can be, sir, they can be plicated either from the anterior side or from the posterior side. Sometimes the Lee-Comte maneuver can be done.
Yeah, you do plicated but only if they're usually done to amusement. I don't think they would like to do.
Sir, the right pulmonary artery can be placed over the aortic arch so that it does not compress over the respiratory tract. And
all at what age should we operate?
As early as possible.
Now, what age do we do regular tetralogy? What age do we do repair nowadays?
Sir, 3 to 4 months. Within 6 months.
5 to 6 months. Sometimes we do later also.
Yes.
But in these children, what age do we do?
This has poorer prognosis, sir. So as soon as possible, it should be operated. But the lesser the stridor, the better is the prognosis. So
a child with stridor with these symptoms should but we generally tend to do it quite later in life because you have to replace the conduit. This is not ICR. Conduit will have to be replaced later. So unless there are compressive symptoms, we actually tend to do slightly maybe 1.5 years age also. If the child has compressive symptoms like this child, then you should consider slightly earlier age. Otherwise, no.
Yes, sir.
So overall, surgery is, very difficult in these people. Many surgeons would not be able to do surgery. Absent pulmonary valve is kind of a very big challenge for surgery. It's not like a usual TOF. And they have bronchial issue, tracheal issue, tracheomalacia. So surgery is very, very challenging, very higher mortality, less rewarding.
Yes, and even after surgery, the symptoms can persist because of the continuous pressure over the respiratory tract by the branches of the pulmonary arteries.
Yeah. So I said there could be tracheomalacia. So whenever, suppose you have to do cardiac surgery with some tracheal surgery, the mortality, long-term outlook is very bad.
Yes.
Mortality high, morbidity is also high.
Some doctors preferred giving a stent, sir, either endobronchial or from outside. But
yeah, those are anecdotal far in between, but all this, basically overall prognosis is bad.
Overall prognosis is bad.
Yeah.
Okay. Biswas, one quick question. What are all the murmurs you can get in TOF?
TOF. Sir, if the pulmonary stenosis is not significant, so then we can get a murmur of pulmonary stenosis. If there is a significant MAPCA, sir, we can get a pulmonary continuous murmur, sir. If the branched pulmonary artery stenosis, there is stenosis of branched pulmonary artery, then we can also get a continuous murmur.
All right. What are the VSD?
Associated defects.
Pardon, sir?
Associated defects, yeah.
Associated defects with the tetralogy of thallus.
Yeah.
So there may be the right-sided aortic arch associated with the tetralogy of thallus.
So what does it lead to?
There may be some compressive symptoms due to vascular ring formations.
No,
And-
auscultation, murmurs. Right intercast, very rarely you can get a thrill and a murmur of the right sternocleidomastoid joint. That's one of the murmurs. Plus your EDM, the PR murmur also you got. Okay. Yeah. Okay.
Aortic regurgitation murmur can be there.
Can be there, sir. Yes, ma'am.
Absent pulmonary valve, you have already seen murmur due to this. Isn't it?
Yes.
PDA can be there.
PDA can be there.
So all these associated anomalies.
All right.
Okay, I think we'll go on to the Dr. Majumdar there.
Yeah.
Sir.
Dr. Biswas, well done. Very nice.
Thank you, sir.
Thank you.
Dr. Majumdar?
Yes, sir. I will start my proceedings.
Yes.
Yeah. Please
Yes,
do.
sir. Good afternoon. It is a nice case presented by Dr. Pallab Biswas, and it is a good learning case too, because we theoretically sometimes discuss, but rarely we see day-to-day these types of case. And thanks all the examiners and the chairperson for nicely conducting this meeting. Now today we will discuss about the tetralogy of the fellow with absent pulmonary valve syndrome. I will focus mainly on the clinical feature, pathophysiology, diagnosis, and some medical management, though medical management is not very important and has got very minimal role. And the surgical aspect will be dealt by Dr. Rajushi Basu, Associate Professor, Department of Cardiology in our institution of Arjigor Medical College. So absent pulmonary valve syndrome, it is a dysplasia or absence of leaflet tissue and severe incompetence of the pulmonary valve, pulmonary annular stenosis, and dilatation of the pulmonary artery system, often leading to a varying degree of airway compression at the tracheal and major bronchial arborization level. Absent pulmonary valve commonly found as a variant of tetralogy of Fallot with a reported incidence of 3 to 6% in these patients. Now there are various associations that can be seen with absent pulmonary valve syndrome, like type B interrupted aortic arch, transposition of greater is very rarely, pulmonary branching abnormalities that can be occur, sometimes presents, atrioventricular septal defect, PDA, which is practically not associated but very rarely it may be associated, tricuspid atresia, double outed right ventricle, T-George syndrome or Marfan syndrome. Now what are the types of absent pulmonary valve syndrome? The Fallot type, which is the commonest type, already the case presented today, it additionally has VSD, aortic overriding, and ductal agenesis, which was first emphasized by Emanuelidis et al. And is the most common variety. And there may be non-tau variety that is extremely rare and only few case reports are available. Fallot's type of absent pulmonary valve syndrome has been associated with 22q11.2 microdeletion. Now, presence of accessory findings may be present in the prenatal period like hydramnios or pulmonary hypoplasia. These two indicate poorer outcome, and soft tissue markers like thymic abnormality, hypoplasia or aplasia or IUGR associated with additional aortic arch abnormalities need to be searched for conjunctival and abnormality also in these patients. Now, top with absent pulmonary valve. This is the most common variety. Chivers first give the description of this anomaly way back in 1847. So, this entity was known very early in our medical history, but first detailed case report was published in 1927 by Puj et al. Fallot type of absent pulmonary valve syndrome and ductal agenesis was first emphasized, already I have mentioned, by Emanuelidis et al. In the most common variety. Irrespective of the fact that whether it is a Fallot type or non-Fallot type of absent pulmonary valve syndrome, both share common features, namely rudimentary or absent pulmonary valve, the dilated main pulmonary artery with or without dilatation of its branches. Already we have seen this today's case and echo was classical like that. Anatomical characteristic of the top with absent pulmonary valve syndrome. Ductus arteriosus is nearly always absent, very rarely it is present. Typical left to right shunt at the ventricular level. About 50% of the patient, there is also right-sided aortic arch, as our case today, and the condition may be associated with absent or aortic origin of the branch pulmonary artery. This is one important aspect. Sometimes origin of a branch of the pulmonary artery may not be from a pulmonary artery, may be from the aorta. Before surgery, these parts should be assessed also because this has huge surgical value. To and fro flow at the site of absent pulmonary valve and systolic pressure gradient across narrowed pulmonary valve. This is characteristic, also seen today's case. Now, what are the possible theories why this absent pulmonary valve syndrome? Factors such as orientation of the infundibulum, the degree of valvular stenosis has been held responsible directly or indirectly for this vascular dilatation. There is some post-stenotic dilatation theory, but that seems not very good because so much of huge dilatation cannot be explained only by post-stenotic dilatation theory. Now, there is an interesting theory. As the ductal outlet is absent, the blood entering into the pulmonary circulation cannot be decompressed and may lead to the interarterial intrapulmonary artery dilatation and valvular regurgitation and possible non-development of the pulmonary valve. This theory is sometimes accepted by many persons, but exact theory is not known. So dilatation of the pulmonary artery may be a primary event. That is also one theory because histological evidence of cystic medial necrosis of the pulmonary arterial walls can be seen. Abnormal branching pattern of the pulmonary arteries in severely affected infants is also present. An animal model has showed intra-uterine bronchial anomalies with smaller diameter of the bronchial and bronchioles. Now, what are the types of pulmonary artery dilatation? This is very important because this has role in surgical value and also in prognosis of the patient. One can be balloon type dilatation. Here, bulbous expansion of the pulmonary artery with indistinct bifurcation in the bilateral pulmonary artery, like balloon. And another one is clover type, but bulbous expansion of the pulmonary artery with dilatation of each of the bifurcated pulmonary artery. Pavaju et al. In the study found that the patient with balloon type pulmonary artery morphology are likely to require mechanical ventilation and has a poorer prognosis than patients with clover type of morphology. The pathology of respiratory obstruction. This is very important because patient usually presents with respiratory tract obstruction like features, and patients who have got severe respiratory tract obstruction like features have poor prognosis. The compression of the larger bronchi by dilated pulmonary artery can cause airway obstruction and respiratory distress during infancy. Compression of the interpulmonary bronchi by abnormal tufts of smaller pulmonary arteries and also reduction in the number of the alveoli. This is also important. And this may explain why surgical relief of the larger airway compression alone is not always effective in reversing the severe obstructive respiratory disease. So this is because of maybe some reduction of the number of alveoli and compression of the interpulmonary bronchi by abnormal tufts of smaller pulmonary arterioles. That part cannot be tackled by surgery. Now, what are the clinical features? Our case was classical, and these are the features: frequent respiratory tract infection, failure to thrive, poor appetite, rapid breathing, wheezing, and sometimes obstructive component like stridor. Lung collapse like atelectasis and pneumonia may be the presentation. Patients are at increased risk of hypoxemia, heart failure, respiratory failure, and combination of these events. Pulmonary complication rather than the intercardial defect determines the prognosis and may be the indicator of the mortality. Now, clinical feature, already our case also we see to and fro classical systolo-diastolic murmur and a single second heart sound because P2 is absent. Most newborns are initially mildly cyanotic, though our case was not cyanotic, maybe cyanosis was missed. But most newborns are usually cyanotic, but this usually becomes less apparent during the first week of life. Around 40% of the patients have some degree of respiratory distress at birth, since there is usually less RVOT obstruction than other forms of TOP. As pulmonary vascular resistance falls, infants usually develop signs of increased pulmonary blood flow and may develop features of heart failure. Natural course, the size of the pulmonary annulus and therefore the severity of the pulmonary regurgitation substantially influence the patient morbidity and mortality. Patients with a smaller and more stenotic annulus are subject to risk akin to those typical of tetralogy of Fallot. Because patient who has severe obstruction, that may mimic like Fallot. Patient who has got minimal obstruction, huge PR, that may present with heart failure. Now, what are the investigations? These are the investigations usually done: ECG, echocardiogram, chest X-ray, cardiac CT, MRI, and fetal echo is very important nowadays for prenatal diagnosis. A good quality fetal echo almost diagnose some abnormality or can give an idea of possibility of absent pulmonary valve, and this may require counseling of the parents because this is prognosis of these patients may not be so good like top. And genetic testing is also important. So this is the ECG. Usually right ventricular hypertrophy and right atrial enlargement is found. No classical feature is found with absent pulmonary valve. And these are the X-ray. Our case was classical. The model cardiac salute is usually in that. There is prominent bulge in the left upper border caused by the massively dilated proximal pulmonary artery. Normal peripheral vascular marking, but sometimes there may be some plethora, and some infants also demonstrate lower emphysema. And these are the echo finding. Our case already showed. Pulmonary valve leaflets are either completely absent or may have an uneven rim of rudimentary valve. So you have to never mistake that some rudimentary tissue has presence of pulmonary valve, because you will see a definite gap in between the rudimentary tissue, as in our case echo also shown that. And there is some pulmonary degree of pulmonary stenosis, and usually severe pulmonary regurgitation is present that can be picked up by CW wave and also in color flow. Massive pulmonary artery aneurysm develops during fetal life. It compresses the developing trachea and bronchi throughout the fetal life. The clinical symptoms of respiratory compression may arise. These are the VSD in top variety. So, what are the role of other investigations? Usually, a good quality echo is sufficient to diagnose the top with absent pulmonary valve, and that may be sufficient. But sometimes there may be some problem that you cannot delineate whether branch pulmonary artery are arising from any other arteries, or you want to show the better view of the aortic arch. In that case, we can do CMRI, CT angiogram. CT angiogram and CMRI imaging for preoperative assessment. CT angiogram and CMRI could be justified as a complementary imaging for any patient in whom clinical or echocardiographic data is insufficient for monitoring decision taking or surgical planning. It is not routinely done, because in young children, MRI may need general anesthesia and CT angiogram may need profound sedation or general anesthesia, because child is restless. So CT and MRI can be done only when if further tests are required, because clinical feature or echocardiography image is not sufficient to stamp the diagnosis, or we are looking for extra diagnosis like origin of the pulmonary artery branch or what is the condition of the aortic arch. Cardiac MRI fulfills this role without irradiation and provides both anatomical and functional information, helpful in assessing extracardiac vessel as well as coronary artery anatomy. That is also important. That can be assessed by CT angiogram and CMRI, and can avoid invasive cardiac cath. Advantage of CT angiogram over MRI. Images available in MRI do not have necessary spatial resolution to assess small anatomical structure. The tracheobronchial tree is also better assessed by CT than MRI. Cardiothoracic CT required less time, thus beneficial for hemodynamically unstable patient. Generally, children less than 7 years of age will require a CMR under general anesthesia. That is the disadvantage. Now, this is another picture of a CT aortoangiography in a patient with top with absent pulmonary valve. In the transverse view, we show the hypoplasia of the pulmonary valve ring and rudimentary cast and massive dilatation of the pulmonary arteries and lung parenchymal ventilatory abnormality secondary to bronchial compression. Now, what are the treatments? Patients who present with severe respiratory compromise immediately after birth in the first weeks of life will generally require urgent intervention. For severely affected infants, some clinical improvement may be gained by front positioning, which allows the pulmonary arteries to fall forward and away from the bronchi. Otherwise, these patients usually require prompt intubation and positive airway pressure ventilation to maintain their airway. Infants without severe symptoms most often have surgery within the first 3 to 6 months of life. Complete repair is the procedure of choice. A valve conduit may be used to restore competence of the pulmonary valve, and aneurysmal PA is plicated. Endobronchial stenting sometimes can be done, though results are not very satisfactory. Endobronchial placement of the metallic stent can be successfully carried out in infants who are at poor medical condition with external compression of the bronchus by dilated pulmonary artery. The possible complications include infection, restenosis, stent migration, erosion, and perforation. But this type of stent placement is generally low, easy to perform, and the clinical improvement is usually evident within a short time. With growth of the child, the stent becomes loose and can be removed. That is important. The prenatal diagnosis, this is very important. Despite increasing knowledge and prenatal diagnosis of the Absent pulmonary valve syndrome remains a challenge, a major step in patient counseling given to a serious postnatal complication. Pulmonary artery dilatation on the prenatal ultrasonography may be a normal variant, that is very important. However, identification may be pulmonary artery dilatation can be also present in isolated pulmonary valve stenosis, ductus arteriosus constriction, and situation of pulmonary hypertension or a top with absent pulmonary valve syndrome. Fetal MRI has been useful in evaluating the effects of congenital lung lesion in lung development and indicating severity of the pulmonary hyperplasia. Currently, no known definitive fetal marker of disease severity is available. Although severe series report good results with patients diagnosed prenatally, these patients generally have a much poorer prognosis than the classic form, and the course of the disease is unpredictable. This is the transverse 5-chamber view showing ventricular septal defect and overriding of the aorta and a massively dilated right pulmonary artery seen in this plane. This is 3-vessel view in a grayscale and color Doppler, presence of severely dilated left pulmonary artery and right pulmonary artery and pulmonary artery, in case of top with absent pulmonary valve. So, unrepaired top with absent pulmonary valve, rarely survived into a young adulthood. Prenatal diagnosis carries a poor prognosis. In fetus that survive, morbidity and mortality rates are high, usually because of bronchial compression from highly pulsatile massive pulmonary artery, which can lead to bronchomalacia or air trapping. Typically, patients present early in life with cyanosis, recurrent respiratory tract infection, and failure to thrive and heart failure. Take home message: absent pulmonary valve with top usually present with airway obstruction and respiratory distress during infancy. Prognosis directly related to the degree of the tracheobronchial obstruction secondary to the pulmonary artery dilatation, and airway compromise is the predominant concern, including atelectasis, pneumothorax, and pneumonia. Symptomatic neonates should be corrected surgery on an urgent basis. Asymptomatic children should be done under elective surgery in the first 3 to 6 months of life. Thank you. And the surgical part will be talked by Dr. Rajeshri Basu, Associate Professor, Department of Cardiology, Arjigar Medical College, Cardiothoracic Surgery, Arjigar Medical College.
Thank you. Thank you, everybody. It's been a nice presentation by Dr. Biswas and elucidation by Professor Udik Majumdar and respected members. They have present their convening the meeting. That's a very nice. I was hearing all the things. It was really excellent to hear those things. Let me now share the screen of the surgery. Just wait, I'm trying to share. Yeah, the surgical management of the tetralogy of fellow with absent pulmonary valve.
No, we are not able to see the screen. You just share screen. You just share your screen.
Have you unshared, Doctor, this?
This one, yeah.
No, I have. You will not able to see.
No, we are not able to see your slides.
Sir, this is Kishore from technical side. So you can able to see share screen, sir, on your screen. Yeah, it's loading now.
Yeah.
Can you see now?
Yes, please.
Just
Yeah.
No, it is in the process.
Started, but you can see. You have to double click. Yes.
Yeah, now you can see it.
The surgical management of tetralogy of fellow with absent pulmonary valve.
Can we just have a full screen?
Full slide presentation.
From this seat not possible. Sir has to download.
Yeah, Dr. Basu. Yeah.
Sir has to download and open from PPT. Then you can has to make PPT full screen.
Is it not visible?
That's visible.
It's
That doesn't
visible,
look
sir.
like a PowerPoint.
It is fine, Dr. Rajshri. You can go ahead. Looks
Okay. So the repair of tetralogy of fellow with absent pulmonary valve is a multiple procedures, as Dr. Majumdar was telling. And it's in 5% of patients have tetralogy of fellow with absent pulmonary valve. What are the problems in surgery? The pulmonary annulus is hypoplastic. There is some nubbins of the vestigial valve, small valves which are not acting as valves. The branch pulmonary arteries and the main pulmonaries are aneurysmal, almost twice to thrice the size of the normal valve. The respiratory teachers are saying, what is the Z valve? It is more on the higher side of the Z valve. And definitely the PDA is in most of the cases, if not all, are absent. So the most common problem of tetralogy of Fallot with absent pulmonary valve is the tracheobronchial compression. The neonatal variety, they present with respiratory distress because of the compression of tracheobronchial tree by the dilated pulmonary arteries and has leads to heart failure. But in infancy, they was telling that tetralogy of the cyanotic type, it is less symptomatic. It is having cyanotic spells and heart failure, but the compression level is lesser. So what are the major debates of the surgical intervention? The major debates of surgical interventions are management of the aneurysmal pulmonary arteries and the placement of the pulmonary valve in the RVOT. Apart from the other surgeries of the tetralogy of Fallot, repairing of the VSD, removing the band obstruction, infundibular stenosis, all those things. The two major debates are management of the aneurysmal pulmonary arteries and placement of a pulmonary valve in the RVOT. The different surgical options. The plication. This was the first came out. The plication of the main pulmonary artery, the right pulmonary, the left pulmonary artery. Usually, the posterior surface is not plicated because they are grossly adherent to the bronchus. Usually, the anterior surface is plicated. As Professor Majumdar was telling about that clover type of deformity or the balloon type of deformity, the clover type of deformity is easier to placate, and you always placate the anterior surface. You cut and then placate, and then either you put a transannular patch. In some cases, people go away with a transannular patch, but that in infancy, in older children. But in younger children, you may have to put in a new pulmonary valve using a PTFE. You have to fold the PTFE and stitch it to the pulmonary annulus. And usual repair of the VSD with RVOP stenosis are being done. This person, he revolutionized this operation of tetralogy of Fallot with absent pulmonary valve. He was the person who made it simpler, more effective, and having a less mortality. Raw same underlaid. He removed the maximum portion of the pulmonary arterial tissue. He said if the pulmonary arterial tissue is left, that will cause more and more compression of the bronchus. That is the most important thing. He advocated complete excision of the main pulmonary left and right pulmonary arteries. It decreases the tracheobronchial compression, and he placed a homograph valve in the pulmonary outflow. Usually, this is the thing. What Anderleger has told, that we don't put the patient on prolonged circulatory arrest or prolonged cross-clamp and all those things. We put the patient on cross-clamp and circulatory arrest with 15 minutes of total circulatory arrest. And you give a 2 minute of intermittent perfusion, you're giving cardioplasty. In that way, the brain is safe, the heart is safe, the lungs are protected, and we get a very good result. The result, my fellow colleagues and seniors, does not depend on not on how good the surgeon has operated. It is also depends on a lot of other factors, like how much compression is there, tracheomalacia is there, and as Professor Majumdar was telling, whether the alveolar development is less, whether the less amount of alveoli are present. So the two crux that Anderleger has told is complete mobilization of the main pulmonary artery, right pulmonary artery, and mobilization of the branch pulmonary artery is right up to the hilum. Right up to the hilum, mind that has to be done. This is the thing. He has mobilized the pulmonary arteries, as you can see, he has mobilized the pulmonary arteries right up to this. The left hilum, which is the main continuation of the pulmonary artery, and has dissected the aorta, lifted it up, and mobilized up to the right pulmonary artery, right up to the hilum, and has retracted the superior vena. This is the superior vena cava, the cannula inside, and retracted the superior vena cava also. This is the aorta. This is the cross clamp in situ, and the cardioplegic needle in there, and then he has retracted the whole right and left pulmonary arteries. Now he has opened the RVOP. You can see this is the aortic valve, and these are the muscle bundles. These are the muscle bundles, the hypertrophic muscle bundles are there. He has opened the RVOP. This is the usual thing for any tetralogy of Fallot. As you all know, you have to remove the infundibular muscle bundles, the septal and the parietal bands. The parietal bands have to be dissected. The septal bands have to be incised. And then after you do it, you can clearly see the VSD. You can see clearly the aortic valve leaflets, and you can see the rudimentary pulmonary valve tissues. And you have to dissect so much that there is no obstruction to the flow of the valve in the right ventricular outflow tract. Then the usual VSD closure. We usually do the VSD closure in interrupted technique. We use plagets. We use 5-0-proline in infants and 6-0-proline in adults. And in this ways, we can be very careful about that we don't injure the bundle, we don't injure the aortic valve, and we close the VSD. Now, the most important crux of the operation. Here it comes. Now we have the VSD is in situ, and we have dissected the pulmonary arteries, and now we increase the incision of the pulmonary arteries right to the right pulmonary artery and right pulmonary artery. Make it a T-shaped incision. We make it a T-shaped incision, and we have dissected right onto the left and right pulmonary artery. We have now cut the main pulmonary artery. We have detached the main pulmonary artery from the right ventricular outflow tract. Detach it. Now we increase the incision right up to the hilum of the left pulmonary artery. The left pulmonary artery has to be cut first, and the left pulmonary artery is divided along with a narrow cuff of the origin of the lower branches. So we dissect right up to the lower branches and leave a narrow cuff. You can see the small openings there, and we have cut up to the narrow cuff and remove these portions of the pulmonary artery. Similarly, we have retracted the aorta. You can see that we have retracted the superior vena cava, we have retracted the aorta and run right below the aorta into the right pulmonary artery, and we have dissected the right pulmonary artery right into the branches of the hilum. Our respected teachers may ask, is it possible to remove, dissect that part of the pulmonary artery? In neonates, where the chances of compression are much more, we dissect more. The branches are very supple. If you can dissect, the branches can be dissected very easily. But in older patients, we leave this posterior portion. We don't dissect the posterior portion. We dissect the anterior portion and leave a cuff of the posterior portion. So you have removed the right pulmonary artery, result in removal of almost all the pulmonary arteries. So you remove the main, the left, and the right pulmonary artery. As Dr. Biswas was telling, the Lecomte maneuver, you bring the pulmonary artery in front of the aorta. It decreases the tension of the suturing. But Anderleger, in his original work, he didn't do the Lecomte maneuver. Lecomte maneuver was actually invented for the in TG operation, the transposition of blood vessels, where we do the Lecomte maneuver to bring the pulmonary arteries in front of the aorta. In total correction of TG, where we'll put the coronary buttons over the pulmonary artery and stitch it to the aorta. But here, Anderleger haven't done a Lecomte maneuver, but Lecomte maneuver can be done in repair of tetralogy of Fallot with absent pulmonary valves. This is the picture of the Lecomte maneuver I have shown. The pulmonary artery has been behind, it has been brought in front and stitched. Now coming to our main operation. Now we stitch the posterior portion of the pulmonary artery. We have removed the whole pulmonary tissue. We stitch the posterior portion of the left, this is the left, and the posterior portion of the right pulmonary artery. So the posterior walls of the right and left divided right pulmonary arteries are approximated with a running suture of Prolene sutures. Usually in small children we use a 6-0 Prolene suture. In slightly older adults we use a 5-0 Prolene suture. And the mobilization of the branch pulmonary arteries is facilitates the anastomosis. In older infants, we occasionally leave some posterior tissue. As I was telling, they leave some posterior tissue because it's difficult to mobilize the arteries there and to facilitate a tension-free anastomosis. Now, this is the size of the valve conduit. Here, Anderleger has used an homograph valve, but when we were doing our MCH and our post-MCH days, the most important conduit that we used are Contegra. It's a bovine jugular vein, which we used for all these pulmonary annulus and pulmonary arterial reconstruction. We used Contegra. It's nothing but a bovine jugular vein, treated definitely, and we use that. But here now, then another came within our training periods, where there's a LabCorp valve. Now the homograph valve has come to the market, and Anderleger has used the homograph valve, and it's an aortic homograph. So he's used a appropriate pulmonary homograph is anastomosed to the pulmonary artery. In the when the posterior wall is repaired, we anastomose the anterior wall with that upper portion of the pulmonary artery. This is the valve. This is the valve. So you have stitched the pulmonary artery, brought the two pulmonary arteries there, then stitched the homograft, upper portion of the homograft of pulmonary artery. Under laser, what he did, he removed the cross-clamp from this region and repaired the pulmonary annulus without the cross-clamp on a slightly low temperature, so the return is less. But for the beginners or the surgeons, even for us also, we don't remove the cross-clamp. It's very difficult to see that there will be a lot of blood coming in the field and obstructing our field. Now we stitch the posterior portion of the RVOT, right ventricular outflow tract. This is the VST. The posterior portion, right ventricular outflow tract, with that posterior portion of this graft, the homograft or the contact graft, whatever it is. Anterior portion, this is the most important thing I want to highlight. We don't stitch the anterior portion right up to the pulmonary homograft. No, that will cause the stenosis. We use a 0.6% in glutaraldehyde. We remove the portion of the pericardium. We treated it with 0.6% glutaraldehyde, and we use this glutaraldehyde treated patch to stitch the anterior portion of the homograft with the RVO. So this prevents the stenosis. So what are the surgical tips that has to be taken from this meeting? The circulatory arrest is the most important thing. Previously, a lot of people had tried to thought they can go with circulatory arrest, do the lesser procedure, but when they do a lesser procedure, plication or putting in our valves or putting in a transcellular patch, even though the results are not are equal, the mortality statistics are equal, but the 5-year, 10-year survival rate, the 5-year, 10-year symptoms, they are much worse in those patients where it is the transcellular patch or a valve. But those patients where after underlaser invented this thing about this pulmonary homograft resection of almost all of the aneurysmal pulmonary tissues, the results have become much better. So what are the surgical tips? Circulatory arrest with intermittent perfusion. And definitely when you put the circulatory arrest, you need an infrared spectroscopy or NIRS for the measurement of cerebral oxidation. There is no problem in the perfusion of the cerebral vessels. So if you do 15 minutes circulatory arrest, then 2 minutes of perfusion with a cardioplegia, and again 15 minutes of cardiac arrest. The vertical surgical tips, the most important thing, we leave a small ASD. If they have created a PFO, if it is a PFO, we leave it. Or if you have created an ASD for shunting of the left side, for venting the left side, we leave the small ASD. We do keep an LA line to, through that ASD opening to measure the LA pressure. Because through that LA pressure, we can know definitely what is the perfusion pressure. Because the right atrial perfusion, right atrial pressure may not always give the correct pressure of the perfusion on the left side. The left-sided perfusion pressure may be, right-sided perfusion pressures may be very high, but the left-sided perfusions are low. Patient may require a lot of fluids, and we are not giving fluids. The kidney will shut down. And again, if the left-sided perfusion pressures are high, then we have to put in inotrost for this patient. That's why the LA line is a must. We put an atrial and ventricular pacing wire, so do a sequential pacing, and definitely we need a transient esophageal echocardiography to check the repair. This is a must. So what is the advantage of this under laser technique? Once you get accustomed, once you start doing it, this technique of repair is relatively simple and reproducible. People can do it. There is a minimum distortion of the pulmonary arteries. As we have removed the portion of the pulmonary artery and put in a convict, there is minimum distortion of the pulmonary arteries. And later on, in the adult life, the minimal compression of the tracheobronchial tree. Before I conclude, I would like to say the patients who present with respiratory distress, the infants or the children, they fear worse. The patients who present in early life, even they do have compression, but they have got respiratory distress, they fear better. The chances of survival of 5 years and 10 years are better. Number one. About the tracheomalacia, the aneurysmal pulmonary arteries, they press over the trachea. The cartilages become very soft and they buckle inside the pulmonary arteries, they buckle inside the airways and causes these problems. Even if the angio, the CTPA and the CT scan shows the bronchus size to be absolutely normal, but still after we have taken them out of ventilator, maybe sometimes the patient may not be able to breathe. The surgery is okay, the perfusion pressures are okay, the saturations are okay, but suddenly the saturation started dropping and the patients will not be able to breathe. There will be collapse of the lung on both sides. Or there will be infection in the atelectasis of the lung. In those cases, we will put the patients on a long-term ventilation. So tetralogy of Fallot, as I have seen, can be operated and they can be extubated in best centers of the world. In India, they can be extubated on table or in the ICU or in the usually next day. But in these patients of absent pulmonary syndrome, we usually have to keep a long-term ventilation for these patients. Thank you.
Thank you, Dr. Rajesh Srivastava, for